This is the first in a series of 2 lectures on the surgical management of acute type A aortic dissections. It's part of the TSDA teaching curriculum. The first lecture covers the basics of acute type A aortic dissections, while the second lecture covers special clinical scenarios. The focus of the talk will be on the clinical management of this disease, but will be prefaced by a brief review of definitions, epidemiology, pathophysiology, and the presentation and diagnosis of aortic dissections. Acute aortic dissection is an event of sudden onset in which blood leaves the true lumen of the aorta, usually through a discrete point of exit, which is a tear in the intima, and rapidly separates the inner from the outer layer of the aortic media to produce a false lumen. The dissection can propagate in both an antegrade and a retrograde direction. Patients are considered to have an acute aortic dissection when the process is less than 14 days old, a subacute dissection between 2 weeks and 2 months, and a chronic dissection thereafter. There are 2 classification systems for thoracic aortic dissection, called the DeBakey and the Stanford systems. In the DeBakey scheme, dissections involving both the ascending and descending aorta are classified as DeBakey type 1, those limited to the ascending aorta as DeBakey type 2, while those involving only the aorta distal to the takeoff of the left subclavian artery are classified as type 3 and subdivided into 3A if they stop proximal to the renal arteries and type 3B if they do not. The Stanford system, which is somewhat simpler, divides thoracic aortic dissections into those involving the ascending aorta, which are called type A, and those limited to the descending thoracic aorta distal to the left subclavian artery, which are called type B. The true incidence of acute aortic dissection is unknown because many patients don't survive to diagnosis. In one autopsy series, the antemortem diagnosis was made in only 15% of patients. Autopsy studies from industrialized countries have reported incidences between 5 and 10 cases per million people per year. The incidence of aortic dissection is related to the prevalence of risk factors, the most important being untreated hypertension and diseases of the aortic wall. Other risk factors are presented in this slide. 2 factors, an initiating event and a structural weakness of the arterial wall, contribute to dissection of the aorta. Controversy exists as to whether an intimal tear is consistently present in acute aortic dissection, and thus whether an intimal tear is a requisite for a dissection. Development of an intimal tear, allowing for passage of blood under high pressure into the aortic media, and the development of a false lumen represents the conventional scenario. This is depicted in the CT scan on the left and the cartoon on the right, where the purple arrow represents blood flow from the true lumen through the intimal tear into the false lumen. Alternatively, rupture of aortic vasovasorum can be the inciting event which initiates an intramural hemorrhage and subsequent dissection. This viewpoint is supported by intraoperative and autopsy observations of aortic dissections without the presence of an intimal tear. The CT scan with contrast demonstrates intramural hematoma of the ascending aorta without a dissection flap, while the pathologic specimen demonstrates thrombus in the media of the aortic wall. The yellow arrow in each case points to intramural thrombus. Once a cleavage plane exists in the media, the aortic wall floating within the lumen is termed the dissection flap and is composed of the aortic intima and partial thickness media. It divides the true lumen from the false lumen. The primary tear in a type A aortic dissection is most commonly in the ascending aorta, and the dissection plane follows a somewhat predictable course, spiraling around the arch and into the descending thoracic and abdominal aorta. When the dissection involves the femoral arteries, it more commonly involves the left side. The dissection may propagate in a retrograde fashion for a variable distance as well, and involves the aortic root in roughly 10 to 15% of patients. Myocardial ischemia from coronary occlusion or osteal disruption and rupture into the pericardium resulting in tamponade are the cause of death in as many as 80% of fatalities due to type A dissections. Free rupture into the mediastinum or pleural spaces and acute aortic insufficiency leading to left ventricular failure are other mechanisms that lead to death. The cartoons demonstrate the mechanism of tamponade in aortic dissection, while the CT on the right demonstrates the radiographic stigmata of hemopericardium. The diagnosis of aortic dissection requires a high level of suspicion. As many as 30% of patients are initially misdiagnosed. Classic symptoms include acute onset chest pain radiating to the back. Often patients can recall exactly what they were doing at the onset of the pain. Patients suffering from an aortic dissection appear ill. Tachycardia is usually accompanied by hypertension due to the combination of baseline essential hypertension and increased catecholamine levels from pain and anxiety. Chest x-rays are often abnormal, with classic features including a widened mediastinum shown by the blue arrow, rightward tracheal displacement shown by the yellow arrow, an irregular aortic contour with loss of the aortic knob, an indistinct aortopulmonary window, and a left-sided pleural effusion. However, the chest x-ray is normal in about 10% of patients presenting with dissections. The electrocardiogram in most patients with an acute aortic dissection is either normal or shows only nonspecific changes. Since many patients with aortic dissection have a long-standing history of hypertension, the EKG can show evidence of left ventricular hypertrophy, shown here by the increased QRS voltage in the precordial leads and the T-wave inversions in the lateral leads. Of note, ST segment elevation rarely occurs in acute aortic dissection, but ST segment depression is present in roughly 1/3 of patients. Transesophageal echocardiography offers excellent sensitivity and specificity in diagnosing type A aortic dissections. This image demonstrates a mid-esophageal long-axis view of the aortic root with a dissection flap. Advantages include avoidance of intravenous contrast and radiation. However, it requires operator expertise, and when a dissection is suspected, is most safely performed in the operating room under general anesthesia. Due to their widespread availability and excellent sensitivity and specificity, CT scans are the most common way aortic dissections are diagnosed. In this study, the dissection begins in the arch and tracks around to the descending thoracic aorta. The intimal tear is visible just proximal to the takeoff of the innominate artery. The initial management of patients with a diagnosis of acute type A aortic dissection involves reducing the systolic blood pressure to the lowest level that is tolerated in order to limit propagation of the dissection and chances of free rupture. Short-acting beta blockade should be started first, both for pressure control and anti-impulse therapy, with the goal of lowering the heart rate to less than 60 beats per minute. If the systolic blood pressure remains above 100 millimeters of mercury, with good mentation and renal function, intravenous sodium nitroprusside should be added. Niprite should not be used without beta blockade first, since vasodilatation induces reflex activation of the sympathetic nervous system, leading to enhanced ventricular contraction and increased aortic shear stress. The EKG, oxygen saturation, and blood pressure should be continuously monitored, and in the absence of contraindications to surgery, such as patient preference, advanced pulmonary disease, hemorrhagic stroke, or extremely advanced age, the patient should be transferred to a center capable of performing cardiac surgery. The role of coronary angiography in the setting of acute aortic dissection is somewhat controversial. It has putative benefits, but increases the risk of a catastrophic preoperative complication. One study by Penn and colleagues retrospectively analyzed the outcome of 122 patients who underwent emergency aortic surgery, primarily for type A aortic dissection. There was a statistically insignificant trend towards higher in-hospital mortality in patients who underwent coronary angiography. More importantly, coronary angiogram had no impact on the incidence of coronary artery bypass grafting. Similarly, a review of the International Registry of Acute Aortic Dissection from 1996 to 2010 confirmed a lack of impact of preoperative cardiac cath on survival, and, in fact, patients who underwent preoperative cath had a higher rate of long-term rehospitalization. The justification for prompt surgical intervention on acute type A but not type B aortic dissections is based on the natural history of these two diseases. The figure presented from Masuda and colleagues' 1991 circulation paper demonstrates survival with non-surgical treatment after acute aortic dissection according to type. Predicted percent survival is represented on the y-axis, while interval from onset of symptoms in years is represented by the x-axis. Modern operative mortality for acute type A aortic dissection ranges from 12.7% to 32.5%, while in-hospital mortality for non-operative treatment, as seen in this figure, is close to 60%. Therefore, in all but the highest risk patients, prompt operative intervention is a standard of care. Managing expectations is an important component of the preoperative discussion with patients. While operative intervention is justified based on improved survival, major complications approach 50%. This slide lists the experience of Chiappini and colleagues reporting on almost 500 consecutive patients treated over 3 decades for acute type A aortic dissections, and presents some common complications. In addition to discussing risks of surgery, it's necessary to discuss the possibility of valve replacement and the prosthetic options. It's also prudent to advise patients of the necessity of groin or axillary cannulation and the distinct possibility of deep hypothermic circulatory arrest. The goals of the operation include finding and resecting the portion of aorta that contains the entry point for the dissection. This is typically the intimal tear in the ascending aorta. Often, if the tear is distal to the aortic root, the valve can be resuspended and the root preserved. If the intimal tear involves the root, or if the patient has a connective tissue disorder or a congenitally bicuspid aortic valve, a root replacement is typically required. If the dissection compromises the patency of one or both of the coronary ostia, coronary bypass will be necessary. The location of the intimal tear typically dictates the extent of aorta that will be reconstructed. If the intimal tear is distal to the sinotubular junction, the patient doesn't have a connective tissue disorder, and the aortic valve is morphologically normal and amenable to resuspension, then the proximal extent of the reconstruction should be at the sinotubular junction. The next slide is an animation which depicts one of many ways of reconstructing the sinotubular junction and resuspending the aortic valve. Bioglue is placed in the false lumen, and the divided layers of the aortic wall are compressed for a minute or two to allow the glue to dry. 2 thin felt strips are cut to an appropriate length and secured to both the inside and outside of the aorta. In this animation, a running mattress suture is used. The valve is then resuspended by placing a pledgeted mattress suture at each commissure and bringing it through the aortic wall at an angle such that it emerges from the top edge of the external felt strip. Finally, the proximal anastomosis to a Dacron tube graft is performed in the conventional fashion. A more conventional operation for acute type A aortic dissection involves the replacement of the lesser curvature of the aortic arch under deep hypothermic circulatory arrest. The advantage of this method is that it allows for examination of the entire arch, resection of more diseased tissue, and for performance of the distal anastomosis without. If the intimal tear cannot be resected using the hemi-arch technique, or if the arch is sufficiently destroyed, then a total arch or elephant trunk procedure may be required. The arch vessels can be reconstructed using a Carrel patch, as shown on the left, or if insufficient tissue is available, they may need to be reattached individually using individual Dacron side branches, as shown on the right. The following slide presents an animation which demonstrates one of many methods of repairing an acute aortic dissection using the hemi-arch technique with an interposition graft beginning at the sinotubular junction. This slide shows an intraoperative photo demonstrating the side branch off the Dacron graft after the distal anastomosis has been performed. The arterial cannula has been moved from the femoral artery up to the side branch, and the graft is being. Chiappini and colleagues retrospectively reviewed almost 500 consecutive patients treated surgically for type A dissections. The in-hospital mortality, including operative deaths, was 22%. Similarly, a report of the International Registry of Acute Aortic Dissection, which was established in 1996, reported a hospital mortality of 26% among over 200 patients treated surgically for type A dissections. In this slide, Kaplan-Meier curves are presented for long-term survival among hospital survivors. Survival was 94.9% and 88.1% at 5 and 10 years respectively. Freedom from reoperation was 92% at 25 years. Survivors of surgery should receive long-term therapy with oral beta blockers and afterload reduction with angiotensin-converting enzyme inhibitors or hydralazine. Alternatively, these images demonstrate CT scans done after repair of a dissection with the hemiarch technique in a 69-year-old man with a paragraph fluid collection which persisted on his 3-month checkup. Images were taken 4 weeks later, which showed an increase in the size of the collection, but no stigmata of infection or extravasation of contrast.